Good afternoon and welcome everyone to our virtual dementia lecture series, which is brought to you through the Cognitive Neurology Clinic and the Integrative Memory Care Clinic of Emory. And so today, this is happening every month. We have topics that are brought to you by, or things that you wanted us to address, and also that we felt in talking with our patients and families that would be important for you on your journey. With me today are my colleagues. I'm Alice Cooper, and we have Ashley Barner, who's the clinical social worker, lead clinical social worker, let me say, over neurology, but also works with me in cognitive neurology. And then also Laura Methers, who is clinical social worker, and I know that she has other titles in the Integrated Memory Care Clinic. She takes care of those things. And so we are so happy to have you here today. And who's with us today, it's going to be Jocelyn Wise, and she will be introduced later, but she's going to be talking about recognizing and addressing signs of depression in individuals with MCI and dementia. And so a few housekeeping details right now. You will be able to ask questions if you drop them in the Q&A, and we will address those at the end of the session, but please don't wait until the end of the session. Once you think of it, go ahead and put it in, and we will be happy to make sure that they get answered. So just remember, this is every month, and hopefully you will join us next month. And if there's anything that you'd like for us to talk about specifically, could you please also drop that in the Q&A and let us know what's on your minds. And so I will turn this over to Ashley to introduce our speaker.
Hey y'all, really excited to have Jocelyn Wise with us today. She is one of the folks that I respect absolutely the most here at Emory. She serves right now as program director of Emory University's Fuqua Center for Late Life Depression, which is a nonprofit organization dedicated to increasing awareness and access to mental health treatment with the goal of eliminating stigma and discrimination experienced by older adults with mental health issues. Jocelyn received both her master's in public health and her master's in social work out in California at UC Los Angeles. And during her training, she was a geriatric social work education consortium scholar and a recipient of all kinds of HRSA fellowship and other awards and grants for her work with older adults. And she is a go-to for information about kind of how best to navigate these different fields. So with that, Jocelyn, I'm going to turn it over to you.
Thank you so much. Let me share my screen. So thank you so much for having me this morning. I am pleased to see some of my favorite social workers at Emory and also folks who I deeply respect. And I'm glad that we picked this topic because I think there's a lot of issues that can be a little confusing around mood changes that you can see when there's also a neurocognitive issue going on. So the way that we'll kind of look at this presentation this morning is kind of starting with, just what is depression, and then layer that on top of, what does depression look like with somebody who might have MCI or dementia, and then try to keep this very practical. What do we need to recognize and how do we help somebody seek help? So I know along the way we'll be getting questions from the audience, and please do that. I think that presentations are much more interesting when there's that kind of interaction with the audience, and I want to make sure that this is useful for you. So we'll just get right into it. So what is depression? It's one of those terms that we kind of hear used a lot in regular speech, I'm so depressed today, or that was so depressing. But when you think about it from a medical standpoint, depression is a medical illness. It's one of those illnesses that's often sort of talked about as if it were by choice or something that has to do with your morals or your, something to do with your strength of character. So it's always really important for me to emphasize that depression is a very legitimate, real medical illness. There are biological, psychological, and environmental factors that can impact depression or trigger depression or increase your risk of developing depression. And it is a condition that is often sort of overlooked. And yet it impacts a really large number of people. Among 65 and older, that translates to over 6 million people, but it is not a normal part of aging. So, that's another thing I hear from people sometimes is, well, of course I'm depressed, this is such a difficult period that I'm in. And, I think as we get older, we're naturally going to be depressed. And that is not what we see in clinical practice or in the research, that as people get older, depression is not an inevitable condition. There can be environmental things happening that trigger depression, but it's not an inevitable part of the aging process. What we do see is high rates of depression among people who have chronic illnesses. And that kind of makes sense when you think about the biological, psychological, and environmental factors that can go into developing depression. So let's talk a little bit more about what we actually use to define major depression. And remember that depression is on a whole spectrum. It could be very mild. You could have some sort of milder symptoms of it. And then you could have major depression. Major depression is on the higher end of the spectrum where it's really become debilitating. So the core criteria are one or both of these two top symptoms. So depressed mood, feeling down or sad, or a lack of interest, or both. And so, I think a lot of folks naturally understand that depression has a depressed mood component to it. What a lot of people miss is that lack of interest. And we're going to talk a little bit more about that too, towards the later part of the presentation, but sort of feeling like, I can't be bothered, blah, just not interested, I have no get up and go. That actually meets criteria for one of the core symptoms of major depression. And then meeting the rest of this criteria, you want to see 5 or more other symptoms. So any of these symptoms kind of alone by itself would not point towards major depression, but kind of in the whole constellation of symptoms, that's what you're looking for with major depression. So feelings of worthlessness or guilt, poor concentration or ability to make decisions, fatigue, agitation or retardation of movement. So feeling kind of jumpy, jittery on the edge of your seat, or slow, sluggish, dragging. Problems with sleep, and that might be sleeping too much, 10, 12, 14 hours a day, or sleeping, having problems falling asleep or staying asleep. So basically sleep disruptions. And then changes in weight or appetite. This is something we pay attention to a good deal in older adults. Weight loss, skipping meals, no appetite. We really take that very seriously among older adults. And then probably the most serious symptom is recurrent thoughts of death or suicidal ideation. So clearly, paying attention to if somebody's saying, I want to die or I'm going to kill myself is a very clear indication that we need to be taking a good look at major depression. So just to kind of hammer home a little bit more, depression is a real medical condition. It involves various parts of the brain, right? So this is a very brief look at some of the main areas of the brain. If you look here at the front of the brain, the cerebral cortex, that's where we have a lot of our high-level functions. The hippocampus, you're probably familiar with in any kind of discussions around dementia. It's largely considered a memory center of the brain. And then the amygdala, that tiny little sort of P-shaped thing near the hippocampus, is part of the limbic system, which is largely related to our emotional system. And in depression, you can actually see brain changes happen. So the hippocampus can get smaller and the amygdala can be overactive. So sometimes people think my brain, a depressed person has a brain that's sluggish and slowed. It's actually more active than it would be when it's not depressed. So I wanted to make sure we covered a bit about pseudo-dementia. This is a question that comes up for me a fair amount of time. People hear this term pseudo-dementia, and it's kind of confusing as to what they're getting at. So pseudo-dementia is a term used to describe cognitive deficits in psychiatric disorders, such as depression. And so, remember, we're looking at the brain, and the brain is super intertwined, right? All these different areas are not operating by themselves. They very much interact with each other. And so you can see changes in somebody's cognition with most of the time major depression. And that can be very confusing for folks as to, why that's happening. And what people often ask me is, how do we tease apart whether somebody is developing dementia symptoms, or is this a result of more of a depression? So the research kind of shows that if you're looking at recall as part of one of the areas of function in the brain, recall for somebody with pseudo-dementia is going to be worse than somebody who is not depressed. So let me make sure that's clear. If you're experiencing significant depression with pseudo-dementia, your recall is not going to be as good as someone who's not depressed, but your recall will probably be better than somebody who has dementia. So what we tend to see with pseudo-dementia is actually more of a cognitive inefficiency, meaning the thinking is not happening as smoothly and as effectively as it normally would when the person is not depressed. And you're also seeing more things like poor attention, versus somebody who has dementia symptoms is more likely having trouble with their cognition due to a lack of ability. And that's tough to tease out. But oftentimes neuropsychological testing can help with really looking deeply at what areas of functioning are being affected. And neuropsychologists can help to tease out is this symptom coming from depression versus dementia? And what we tend to see is changes in executive functioning around switching tasks and shifting attention from thing to thing, so kind of a cognitive flexibility. We tend to see poor effort with pseudo-dementia, so just so depressed that it's hard to make the effort to solve the problems or to think things through. So oftentimes what we do when we see symptoms of what we think is pseudo-dementia, we intensively treat the depression, and that helps to peel away some of the layers and get a clearer picture of what may be going on with somebody. For anyone who's familiar with the medical system and how healthcare works, a lot of times, what you're getting is your best guess diagnosis, and then treatment can actually help to dictate how good that diagnosis was and what next steps make sense. With pseudo-dementia, so again, this cognitive change that you're seeing related to depression, cognitive function generally returns to normal levels. And so, those brain changes in the amygdala and the hippocampus, they can go back. So that's a very hopeful thing to know. Recurrence of depression can be successfully treated. And but it is something to be taken seriously. Pseudo-dementia in moderate to severe depression appears to be a strong predictor of dementia in older adults. So I'm going to talk about this a little bit more later too. But basically, pseudo-dementia, or depression really, is one of those conditions that we have good treatments for, and we want to treat it for all of the quality of life issues and for, being responsible medical providers, but also because we don't want untreated depression to increase somebody's risk of developing a neurocognitive issue in the future. And just a little bit more from some of the research that 71% of those with pseudo-dementia converted to dementia, while only 18% of people in the control group converted to dementia. So I'm going to shift a little bit to focus our topic on how depression, MCI, and dementia kind of look together. So there have been some really interesting studies looking at this, and I'm trying to glean out some of the key findings. So depressive symptoms are frequently seen in persons with Alzheimer's disease, and there's these estimates of maybe 40 to 50%. And remember, again, on that continuum of depression, depressive symptoms doesn't mean major depression, but just some symptoms of depression are pretty common among folks with Alzheimer's disease. Major depression is seen less frequently, but not uncommonly, 10 to 20% of people with Alzheimer's disease. There's less clear data on the prevalence of depression among persons with MCI. You can see this huge range of 3 to 63%, and that has something to do with the way that the studies are set up, but it's not uncommon to see depressive symptoms. In a recent study, there were results that showed that depression is not a risk factor for developing MCI. So I think there's been this question of, does depression kind of increase your chances of developing MCI? And this is where it gets a little confusing. They seem to be conditions that travel together, but are not causal, right? So it's not that depression has some causality related to developing MCI. But what the research has shown is that among people who have MCI, having depression increases the risk of progressing to dementia. So again, these are kind of not causal conditions, but they tend to travel together. So research is showing that depression accompanies cognitive impairment, but doesn't precede it. And hopefully that makes some sense. So let's get to a more practical piece of this presentation of what are we looking for? How do we recognize depression? And there's many tools for evaluating or screening for depression. I picked just a few that I thought would be relevant. The one that I use the most often is the Patient Health Questionnaire, the PHQ-9. There's also a PHQ-2, so it's a 2-question tool. There's the Geriatric Depression Scale. Both of these have been studied extensively, and I'll show you what they look like. And then there's the Cornell Depression Scale for depression in dementia. And that scale is evaluating for many of the same things, or screening for a lot of the same things, but looking to get input and collateral information from family members or caregivers. So the PHQ-9 and the GDS are really used, could be used for MCI or someone without any cognitive impairment. Once impairment becomes more of the moderate to severe stage, you would really want to use a tool like the Cornell Depression Scale that really includes feedback from others. So the reason I use the PHQ-9 a lot is because it looks very much like the clinical criteria that we went over first. It's a 9-question battery for screening for depression. So it's not, a definitive diagnosis, but it gets you pretty far. So when you're administering this questionnaire, you're really looking at the last 2 weeks of your life. So you're not looking at your entire life. Have you ever experienced these things? But in the last 2 weeks of your life, have you been bothered by any of the following? And you're going through these questions where it says, have you experienced little interest or pleasure in doing things? Not at all, several days, more than half the days, nearly every day. And you're circling the answers for that person that you're doing this screening. Are you feeling down, depressed, or hopeless in the last 2 weeks? This person answered several days in the last 2 weeks. Have you had trouble falling asleep or staying asleep or sleeping too much? More than half the days. Feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, that you're a failure or let yourself or your family down, trouble concentrating, moving or speaking so slowly that people could have noticed, or the opposite, being so fidgety and restless that you've been moving around a lot more than usual, or thoughts that you would be better off dead or of hurting yourself in some way. I'll be honest, I asked this last question about suicide a little differently. I'll say thoughts that you would be better off dead or killing yourself, because sometimes people don't know what hurting yourself means, and I am a very direct person, and I'll just ask specifically using the words killing yourself. And so you add up this, the screening answers, and the PHQ-9 comes with this useful little interpretation of the score. Low scores, minimal depression, mild depression, not so worrisome, maybe something you want to kind of keep an eye on over time, but may not need treatment, probably is not very impairing. Once you get to more of moderate, moderately severe, or severe depression, this is where you really want to pay attention to what people are saying and probably refer to somebody who's going to do further depression interviews and help take next steps to treatment. For somebody who's in that moderately severe to severe depression, I would be pretty aggressive with this. Depression is very impairing. It can really hurt quality of life. And as we were previously discussing, it can impact sort of other neurocognitive disease progression. So that's the PHQ-9. I think that this is one of the most used tools out there. You see it a lot in primary care, but it's been tested in tons of different medical settings. I think it's pretty straightforward and easy to use. Another version of it where they did further studies and they really pulled out the 2 questions that were most helpful for screening for depression is the PHQ-2. And that's just those 2 core criteria for major depression. Last 2 weeks, how often have you been bothered by these things? Little interest or pleasure, feeling down, depressed, or hopeless. And even this 2-question tool has been shown to be useful in identifying depression. And again, remember, this is not diagnostic. So you could certainly be feeling these things and not depressed, but it is a good indicator that you need some further evaluation by a trusted clinician. The geriatric depression scale is a very different format. I honestly don't use this that much, but it's been studied quite a lot. It's a totally valid screening scale. It's a yes/no. It's a yes/no format. And so it's these questions that kind of, I think, make some intuitive sense. Are you basically satisfied with your life? Have you dropped many of your activities and interests? Do you feel that your life is empty? Do you often get bored? Are you in good spirits? I have this on 2 pages. So basically, there's yes/no answers, and then there's also an interpretation of the score. And that, again, is not diagnostic, but it's kind of indicating, is this person showing some evidence that they need to be further evaluated for depression? And the reason I don't use the GDS as much is because I think folks tend to kind of interpret these questions differently. Sometimes they're a little confusing, and it gets conflated with some of the other issues that might be going on due to other medical conditions. The Cornell scale for depression in dementia, I don't have the whole scale here. It's actually kind of a long form, but it's a good scale for using with people who are more impaired, who can answer for themselves some, but also really need a collateral interview to get the full picture. And so it's asking about these different realms of functioning, noticing any mood-related symptoms, behavioral disturbances, physical signs. And what you can see is the questions are a little different, right? So they're looking at anxiety, sadness, lack of reactivity to pleasant events, irritability. We didn't really see that so much in some of the previous screening. Agitation, retardation in movement, physical complaints, loss of interest, appetite, weight loss, lack of energy. Some of the physical symptoms are pretty similar to the other tools. We're also looking at cyclic function, so changes in sort of how people are functioning throughout the day, whether mood is worse in the morning, whether people are having difficulty falling asleep, waking during sleep time, early morning waking, ideational disturbances, feeling like life is not worth living, having poor self-esteem, anticipating the worst, sort of catastrophizing, or delusions of poverty, illness, or loss, like devastating things coming down the line. I do want to talk about apathy. So apathy is a term that you may or may not have heard of. It's that second core the second core criteria in the clinical definition of major depression. It's that feeling of lack of interest. I've heard it described as the get up and go that got up and went, right? Like I feel blah, I feel just kind of like I can't be bothered. And it can involve changes in affect, so sort of your expression of your internal state on the outside. It can involve changes in cognition, and it can involve changes in behavior. Apathy is seen pretty often among disorders of the brain. You see this, again, pretty wide range, but about 36 to 88% of people with Alzheimer's dementia may be experiencing apathy, that kind of like blah feeling. And it's even higher among folks who have frontotemporal dementia. So 60 to 90% of people with FTD tend to experience apathy. Why is it so high among people with FTD? They think apathy kind of originates in the neurocircuits that are related to frontotemporal dementia, so the frontal temporal lobe. And apathy is an important issue to talk about because oftentimes families or caregivers can misinterpret it as something that someone's doing on purpose or something that someone's doing to be oppositional. And so sometimes when I talk with families, they'll say, you know, he can do it because I've seen him do it, but he just won't do it for me or when we're doing things together. And it's a very big shift from can, you know, to can't. Like, will he do it versus he can't do it. And making that shift from, you know, thinking that somebody has a lot of choice in how they're showing up when maybe apathy is actually the driver behind the lack of doing or the lack of effort. Apathy is not always caused by depression. So that's kind of, I think, the point that I'm trying to make with the previous slide as well. In studies, there have been, especially among folks with Alzheimer's, about 37% of people, or in one particular study, of folks with Alzheimer's, they showed that about 37% had apathy, 24% had depression, which leaves 13% with this kind of pure apathy without depression. So it can exist outside of depression, and it's likely related to the cognitive changes that are happening with the Alzheimer's. There was a very similar breakdown in that study seen among Parkinson's patients. Apathy can be difficult to treat, right? So we're going to talk a little bit more about treatment for depression later. But, you know, medications can help with a lot of the bodily symptoms of depression. You know, I'm not totally sure why, but what I've always heard from clinicians that I work with is the apathy part is hard to medicate. You know, it's not something that can probably respond as well to traditional treatments for depression with pharmaceutical products. So there have been some studies of interventions that could be used to treat apathy that are non-pharmaceutical. And so things like music and sensory stimulation, reminiscence therapy, there's been some evidence to show that that can be helpful. But this is one of those areas where I feel like I'm delivering bad news, that apathy is, you know, it's one of those things that we may have to be aware of, have some acceptance around. You know, try to treat and try to engage somebody, try to, you know, of course, address any depression that might be indicated as well. But it's pretty common and it's pretty treatment resistant overall. So that kind of leads me to the next part of this. How do I get help? So what I'm going to do is talk through, sorry, this slide, I think I started something about apathy and then I moved it. So sorry, I'm just realizing there's this like hanging part of a sentence there. Just ignore that. But, you know, I'm going to talk through what are some treatment options with depression. And we're going to talk a little bit about what's reasonable to expect from different treatment options and which ones make sense and which ones may not. So, you know, getting started with treatment can always happen with a medical doctor. So that could be a primary care doctor, it could be your neurologist or psychiatrist. But somebody who, is in the healthcare field is a good place to start, just to have that discussion. I'm seeing some symptoms of depression. I'm wondering about depression. Oftentimes people immediately go to medications. Medications aren't for everybody. What I would say as a rule of thumb is if someone is experiencing major depression, I would really be open-minded to medication, because that means that the severity of their depression is really probably impairing them quite a bit. And medications are probably needed to kind of jumpstart improvements. Therapy and other treatments can be helpful, but I think when someone's on the more severe end of that spectrum, I really encourage people to consider medication right away. Medications, again, depression is a medical illness, and so things that work on your biological system have been helpful. So there are good medications now. There's been a lot of change over the last few decades where new classes of antidepressants have become much more widely used. Old antidepressants actually have really good efficacy. They come with some more side effects. And so that's the only reason why some prescribers really kind of stick to some of the newer ones. It's not to say that the old ones are bad or ineffective. It's just they can have more medication interactions or side effects that are somewhat more complicated with someone who has multiple health issues. So a lot of times you'll see people using Prozac, Lexapro, things in the SSRI category. And even primary care doctors should be pretty comfortable with starting somebody on an SSRI. Beyond that, if you're finding that someone's depression is not improving, a lot of times primary care doctors say, I don't really feel that comfortable being super aggressive with treating depression. I'd like you to see a specialist. So I'd like you to see a psychiatrist. And that's oftentimes when people come to the area of Emory where I work. Medications can help with the bodily symptoms of depression. So that might be sleep, energy, appetite. It's not going to change your personality. It's not going to change your thinking patterns necessarily. So this is the way that I kind of talk with folks about what can you expect from medications. It can help with how you feel, right? For anyone who's experienced depression before, it can come with a lot of physical symptoms: heaviness, sleepiness, exhaustion, no appetite, right? So a lot of those symptoms, if we can alleviate some of that with medication, then you're able to do more and kind of have more momentum to do the other parts of treatment. Other treatment, so the gold standard treatment for major depression, so the more severe versions of depression, medication, talk therapy. Talk therapy, I am a therapist. I believe I've received therapy. I believe very much in therapy. Something to think about with talk therapy with MCI and dementia is, can this person learn and apply new skills and concepts? Sometimes folks come to me as a therapist and they say, just getting it out is helpful, but it's very difficult to progress in therapy if someone can't retain what they have been talking about or working on in terms of skills or make changes in their behavior. So, the level of somebody's impairment kind of dictates whether it really makes sense for them to be in long-term talk therapy. So I've worked with folks who have MCI who do remarkably well in talk therapy, but those are folks who can retain a fair amount of what we've talked about. What can happen in therapy when somebody has cognitive impairment is it sort of feels like they stall out or plateau when they can't retain much, and the conversation each time is sort of the same. And so in those moments, there can be a therapeutic effect, but it doesn't kind of move them forward. And so in those cases, I have no problem with seeing somebody to evaluate to see, can they have the back and forth? Can they retain much from our conversation and make progress in therapy? Or do we need to think about other ways of treating their mood issues? And we'll talk about a little bit of that in a moment. Also think about, one-on-one therapy versus couples or family therapy. I've worked with people who have MCI or dementia and their spouses. And that can also change the dynamic, and it can be helpful in a different way as well. So talk therapy one-on-one for somebody with a fair amount of cognitive impairment may get to that sort of stalled out, plateaued place. But when you add in their partner, there's kind of more, it makes it more dynamic, and it can change sort of more of a family system. And so that might be the format to consider. And therapy for care partners is, I almost always recommend it, almost universally. I think if you have a loved one experiencing dementia, it helps to be in therapy, to have somebody help you process all that's coming up, the grief, the stress, the confusion that can come with these illnesses. So I, I might be really bold and just say universally, I think, care partners can consider therapy. There's some folks who don't want a therapist, and that's okay too. But I think if you're needing support, care partners can oftentimes really benefit from that. Exercise. There's actually been a lot of research to show that exercise can be as effective for treating major depression as other first line treatments. It should say first line treatments. So as effective as antidepressants or talk therapy. So, if you think about, what we know about in terms of cardiovascular health and how exercise impacts our overall functioning of our body and our systems, it makes some sense that, the brain is heavily impacted by our cardiovascular health and can really improve symptoms of mood disorders. So what's not totally known is what's the dose of exercise that helps with depression. I've looked at various studies, and there hasn't been any one, like, you need to get over this particular threshold. Most of the time, what they say is just follow general guidelines for what is heart healthy exercise. And it does help to pick exercise that somebody enjoys, right? If you put me in a boot camp, I don't know how happy I would be, even if I was getting a ton of cardiovascular benefit. So put me in swim class, or put me in, yoga, or whatever is kind of in line with what somebody enjoys. So you're getting benefits to, sort of just enjoyment and affective benefits. And then also, of course, the overall function of your body. Thinking about other treatments that can help with depression, especially in dementia, is just increasing socialization and daily structure. I know that's particularly hard these days with the pandemic, but increasing sunlight exposure, especially in the winter when it gets so dark so early, and outdoor time can definitely help with shifting mood. And you notice there's some ways that circadian rhythms can kind of impact mood. There's seasonal affective disorder and sort of seasonal depression that people experience. So I think just regulating with daily structure and as much orienting kind of sunlight and outdoor time as possible can be helpful. So going back a little bit to talk therapy, I get a question all the time of, how do I find a therapist? How do I find a talk therapist, either for me or somebody I love? There are lots of people of different backgrounds who do talk therapy. Psychologists, right? So PhDs and PsyDs are sort of what people think of the most. This is a doctoral degree where somebody does not prescribe medication. They're not an MD, but they are very skilled in providing talk therapy. There's also folks who focus more on sort of family systems, marriage and family therapy. There's clinical social workers like me, or any of our other participants this morning, and licensed professional counselors. There's also all these other therapy backgrounds that I am not, as familiar with. But what I'm trying to say is there are people of various levels of training who all can do good talk therapy. Some ways of looking for a talk therapist. There's a couple databases on Psychology Today and the American Psychological Association that I use fairly often. You can search by geography, you can search by insurance. Usually there's a little paragraph or some information about who this person is, how they approach their therapy practice, the different populations that they work with. their style. And a lot of times you can kind of tell from what people write, is this somebody who I'll connect with? And there's research to show that that is the number one predictor of whether you're going to get benefit from therapy, is just the rapport or the connection that you have with your therapist, whether you feel like this is someone I could trust, this is someone I want to talk to. So skill level, style of therapy, it matters, but not as much as whether you feel that connection. So a lot of times I tell patients, I can give you some names, I can give you some recommendations, but really it's kind of like dating. You need to find a therapist who you like, someone who you respect and want to connect with. Even if I send you to someone who I think is really skilled and wonderful, if you don't feel that connection, that's okay, right? Keep looking for somebody who you do have that rapport with. And I have these conversation starters here. In case there's somebody in your life who you're noticing changes in their mood and you want to start that conversation around depression. So these are some of the things that I like to say, just to kind of normalize this and give people a chance to open up a little bit. So sometimes when you say the word depression, people kind of shut down. I've heard people say, I'm not crazy. Like, why are you implying that there's something wrong with me? Right. So I try to use the word mood. How's your mood been? There's just so much happening in the world right now. I mean, it's just 100% true, right? Everybody's mood has been impacted by the world. And then there's all the things that are happening in our personal lives that might be impacting our mood. Have you felt this way before? Was there something or someone that helped you in the past? So starting to move a little bit towards problem solving and saying, like what's been useful for you? Letting somebody dictate, what direction they want to go with. This is when I'm trying to encourage somebody to think about therapy. You have such a nice way of expressing yourself. And I'm saying this sincerely. You have such a nice way of expressing yourself. Do you feel better when you talk to someone? And this is a little bit of a trick question because almost everybody feels better when they talk to somebody. So this is my way of trying to open the door towards, you seem to, you do well at talking about what's going on, and you probably would feel better if you had that consistently. Would you be open to speaking to someone about what's going on, or a specialist? And that's another term that I like to use as well. Sometimes when people hear psychiatrist, they shut down, or mental health, they shut down. And so sometimes what I say is, I'd love to connect you with someone who specializes in mood, right? I think maybe that sounds a little bit more approachable. And this last sentence, maybe there have been some changes in your mood, your energy, your sleep, whatever you're kind of noticing as symptoms. This person, right? Insert whatever trusted person you want here, your daughter, your neurologist, your primary care doctor, your husband, whoever wants us to connect with a specialist. So those are some of the ways that I try to kind of make things a little bit more on open and on the table. Some red flags. When we're talking about depression, we want to pay attention to red flags that maybe depression may be something else, but are red flags that this is an emergency. So sudden changes in mood or function. So if someone goes from doing pretty well to kind of taking care of themselves pretty well to kind of not taking care of themselves at all, going from like okay mood to very down, depressed, unable to get out of bed. The sudden changes are a red flag that something serious is happening. Feeling suicidal is always considered a red flag and an emergency. It is a totally legitimate emergency to call 911 or to bring someone to an ER if they're feeling suicidal or if someone gets violent. So I think this is pretty straightforward. What can you do for emergency treatment? 911, going to the emergency room, maybe going to urgent care. I feel like the pandemic has kind of changed everything about how we seek urgent care. But, if someone is feeling suicidal or you're seeing this gross change in their function, I'm giving you permission to seek help for that. What I like to do with an emergency room is I'll call ahead. I'm a medical professional, so it's a little bit of a different relationship, but I'll call ahead. I'll ask to speak to the charge nurse and I'll say, I'm sending this patient in. They're feeling suicidal, right? So when they get there, what I want them assessed for is their suicidality. Another thing you can do is use the Georgia Crisis and Access Line. This is a service that's available throughout the entire state of Georgia. They are a 24-hour hotline of mental health professionals who are basically helping you figure out what your next steps are. So especially if you're at home with a loved one who you're really worried about their safety, you can call them, and they actually have a mobile crisis team, which means they can send somebody to the home to help evaluate and, if necessarily, get somebody to the hospital. So that sounds really good. I'll tell you, that there can be wait times, even when you call. Mobile crisis, depending on where you are in the state, could take an hour to several hours to show up. They'll only send mobile crisis if they deem it an emergency, where their definition is somebody is in danger of killing themselves or killing someone else. So it's a really high bar to meet that crisis definition for psychiatric emergency. But I think that, oftentimes their hotline of counselors can help you figure out, okay, what are local places I could go to seek treatment? They're supposed to even be able to help schedule sometimes. But if you need somebody to bounce things off of and help you figure out the next steps, that is available to everybody in Georgia. So let's say you're seeing somebody for treatment of depression or evaluation of depression. I just had a few tips here. I think the folks in this in the audience may be very aware of these already, but basically try to call ahead and let a clinician know what you're concerned about, what you're seeing at home. Unfortunately, sometimes I've seen people show up to their appointments and they don't seem to be sharing the whole story. And then later you kind of find out there's a lot more going on at home. So if you could send a portal message, if you could call and ask the scheduler to even put a note on the appointment, like patient is very depressed, or this is, a depression evaluation, that can kind of help to make that a more useful visit. For anyone with any sort of cognitive impairment, I would insist that somebody accompany them to the medical appointment. And the reason I put insist is because a lot of times these days, medical offices are telling you, don't come. You can't come with this person. We're only allowing one person in at a time. But if there's any sort of cognitive impairment, that you have to be there in order to make that a useful visit. So insisting that you're allowed to come. Bring current medications. That always helps with kind of figuring out where to go next. What is this person taking, if anything? What should I prescribe that will be, won't interact with things, and also makes sense based on what they've tried already. Make sure that the medical office understands the level of care this person has or doesn't have at home. I've seen notes where medical professionals are under the impression that this person has 24-hour supervision, but they actually live on their own, alone in an apartment, and family checks on them. And so there's a lot of misunderstanding sometimes about what people's level of support is at home. And if you receive treatment, so let's say you get medication started and you're not seeing a lot of improvements in the depression, after a certain number of weeks, I would go back and I would report to the prescriber and say, there's not a whole lot shifting. Kind of be that squeaky wheel, give them the feedback of what you're seeing at home, and make sure that they know, that the medications are not really working, and they can kind of advise you on what to do next or see you back. So I think that is all that I have. I tried to hit on a lot of different things. Here's my slide. This is my contact information. I often do get calls from people with just additional questions. But I do want to take any questions from the audience.
Yeah, we have gotten, excuse me, a couple that have come in. You may have touched on this a little bit, but we had a question that said, for patients who are coming from a different cultural background where depression or mental illness is highly stigmatized, what are some suggestions for sort of how to assess that culturally in a way that maybe the PHQ-2 or 9 or geriatric depression screening, you know, when they just say, no, I'm fine to these answers, how do you do that assessment, I guess?
That's a really great question. And I'll be honest, I've seen this in my own family. You know, I'm Chinese American, and there is a very different kind of view on mental health and what constitutes, you know, a problem culturally. And it is hard. I think this is where some advocacy can come in and be very important with, you know, helping somebody move forward. I have found that among folks who experience a lot of culturally based stigma, if they see their peers kind of shifting in their beliefs or seeking out care differently, that can go a lot farther than hearing it from your adult daughter or from, you know, your husband or your wife. There's something about, you know, when you see somebody you respect who you consider a friend, or maybe, you know, a spiritual leader or somebody who is in your community, that can be very normalizing. I think people tend to have some pushback against their close family members. They can say, well, no, you're just overreacting, or you're misinterpreting me. But any kind of, I think if you can connect somebody with a peer, sometimes those discussions can go a little further. And then I think if you're able to get somebody to a medical professional to look at the depression symptoms, just kind of helping to report what you're seeing, you know, so it may not be endorsements of sadness or lack of interest, but more of like just changes in behavior that can kind of help to paint a picture. I don't know if that fully answers that question, but I think that's a very valid consideration.
I think we could probably spend hours talking about that question, but I think that's a pretty good synopsis. There was also a question about the effectiveness or utility of using psychostimulants as a treatment for apathy. Do you have any thoughts on that?
So stimulants can be used, I see it used somewhat with older adults around things like appetite and energy. In our clinic at Emory, we don't use that, you know, across the board all the time. I think it's really on a case-by-case basis. I don't, you know, giving somebody some more energy is not exactly the same way, not exactly the same thing as getting them to care. But it may help to kind of jumpstart things if they're saying like, I just don't have the energy to do anything. You may want to try to treat that with some stimulants and then see if you can kind of make more progress in other places.
Another question that we often get is sort of what is the relationship potentially between alcohol and dementia and depression, and what do you see in your practice about how alcohol affects people who are living with both?
You know, I was looking at the research around alcohol recently, and it's kind of terrifying. I mean, even small amounts of alcohol can really increase your risk of developing cognitive issues. So I don't think I have like a great answer, but by and large, you know, folks who have certainly a longer depression history, we really recommend that people cut way down or abstain from alcohol. And it's not quite fair, right? So I've had patients say to me, how come I have to be, you know, abstinent from alcohol when other people don't? Well, your brain and your body are somewhat different. You have this strong history of depression, and for you, this alcohol is really going to be working against the things that are probably going to keep you well. That said, you know, there's certainly people with depression who drink some, but certainly we know that alcohol is a depressant. And so it's sort of like, I've heard one of my psychiatrist colleagues describe it as it's like trying to drive your car when you have your foot on the brake, right? You can do it, but you're kind of really setting yourself back. It's harder to treat depression when there's alcohol involved.
One question we also often get is when you're looking for a therapist in the community, is it more important to get somebody who's knowledgeable about depression or who is knowledgeable about the dementia process when you're looking for who's going to be a fit?
That's a tough one. I mean, yeah, in an ideal world, you would want somebody who has both. I realize we're not living in an ideal world, but yeah, I think given some of the topics that we've talked about today, there's an overlap between symptoms of dementia and depression. And so working with someone who is at least aware of that and is looking for those things, and I think that's going to be important. Hopefully you don't have to pick just one or the other. I think probably in the community, you're going to find folks there's almost nobody who doesn't work with depression. It's just a very common mental health condition. But yeah, maybe look for somebody who has some experience with older adults, some experience with maybe caregiving or some of the issues out there, if you can't find somebody who's like a dementia specialist.
Right. Let me see if you have any other questions, please put them in the Q&A. Let me look through this one over here. Any thoughts on different modalities for treatment? Home visits, coming into the office, group versus individual therapy, any particular trends that you have seen as to what's best for this intersection of our patient population?
So I have seen patients almost exclusively via telemedicine for the last 2 years. I saw some patients in person a little bit when things were looking better, and then they were not better. I would say there's benefits to both. I have a fair number of caregivers who I work with who find it very convenient to be able to hop onto a computer, not have to leave their person, and get an hour of therapy. And so that's been remarkably helpful for folks who live far away or who have responsibilities at home that make it difficult to access mental health services. So I really like telemedicine for that. I will say, I think there is more connection that can happen in person. There are particular illnesses where, that those like subtleties that you have in person go a long way. And I do think some people really prefer that in-person visit, and some people like the structure of getting out of the house to do something for themselves. So what I think will happen for me in the future is I'll do both. I'll probably do both telemedicine part-time and also in-person visits part-time. And I like that it gives people more choice. But I do think that in general, therapy is more effective face-to-face.
All right, I think those are all of the questions that we have time for, Jocelyn. I don't know if you can see the chats, but you're getting lots of thank yous, great presentation with great information. We really appreciate the knowledge and expertise that you have shared with our patients and families today. Thank you for your willingness to be able to come and share today. Our next dementia lecture series is going to be March 9th at noon. It will be virtual again. We'll be sending out those reminders. But thank you all for joining us this Wednesday.
Thank you so much.
Thanks, everyone. Jocelyn, thank you very, very much. It was awesome.
You're welcome. It was great to see you guys. Thanks for inviting me.
Likewise.
Take care.
Kevin, are we done recording?